Kingdom. Thank you all for attending our 34th Libyan cardiovascular webinar. Um, we have two excellent presentations by two excellent presenters today. Our first presentation will be by Dr. Ayman Smer, cardiology fellow from the United States, and he's going to present a case in interventional cardiologists. I encourage you all to take part in questions, discussions, and please feel free to ask any questions. The idea of these webinars is interactive and hopefully we could learn from each other. So without any further delay, I will introduce our first speaker, Dr. Ayman Smer. Ayman, the floor is yours.
Assalamu alaikum wa rahmatullah, Khalid and everyone. First, I would like to thank the Libyan Healthcare Society and the cardiovascular webinar organizer for the invitation, and thank you for everything for everyone for showing up. My case today is an interventional case that I saw last year. First, I have no disclosure. So as I said, this is an interventional case I saw last year, but I'm gonna take you back in time to May 22nd, 2011. It was Sunday around 2:45 p.m. when a 61-year-old lady with history of diabetes, hypertension, she was sitting with her daughter going to do some dishes, and just all of a sudden started complaining of chest pain, not feeling well. Then she passed out. The episode was witnessed. Her daughter was there. She called the squad. Immediately, no CPR was done for around 4 minutes. The squad got in there like very quickly, within 5 minutes. And that's her presenting rhythm. I'm gonna let you look at it. So this is like 7 minutes from the chest pain onset. As you can see, polymorphic VT, very rapid heart rate, close to 300. She got one shock of 200 joule, went back to sinus rhythm, and the patient was transferred to the emergency room. She got there at 10 to 3, so kind of pretty quick. Within 25 minutes, she got there. She was hemodynamically stable, blood pressure is 136/89, but she was unresponsive. Labs were unremarkable except mild elevation in her LFTs, and the sugar was high. But there's something missing here. With someone who had a chest pain, you need to see something else, right? So an EKG. And if you look here, her EKG was done at 16:05. Okay, so it took more than 2 hours from the episode to get an EKG. Ideally, you should get an EKG within 10 minutes from the ER presentation. Okay, so as you can see, I'll give you a minute to look at her EKG, sinus rhythm, with the evidence of anterior myocardial injury, diffuse ST segment elevation in the anterior lead going from V1 up to V6. High lateral lead were involved as well, lead 1 AVL with reciprocal chain in the inferior lead. So talking about LAD territory. So this patient was taken to the cath lab, and I want to show you her angiograms. So Khalid, would you mind pulling up her angiogram? So as you can see here, okay, this is obviously going femoral approach, okay, the JL catheter going to the left system. I'm going to play the video for you. I'll give you a minute to look at it. So starting over, I'll try to go slowly. Okay, so if you can see, contrast going to the left main looks okay. This is the LAD going this way and the circ going the other way. Okay, stay for a second. If You can see there's two significant lesions, okay? Two significant lesions. The main one at the proximal LAD, you can see thrombus haziness in the proximal part of LAD, but the circ as well got significant lesion, okay? They called it at the time 80% in the proximal circ. TIMI flow was 3. Okay, so the patient ended up with the bare metal stent, and the reason for that, like no prior history, and no, she's post-cardiac arrest. The policy at our center, that patient that we don't know what's their financial status, what's their compliance, and their post-cardiac arrest, they get by default bare metal stent. Okay, so this is a nice shot here, RAO view. You can see the, so again, this is the left main, this is diagnostic catheter coming this way up, and this is the diagnostic catheter on the left system. Left main looked okay. LAD, this is like post-stenting, good result, and still there's significant lesion in the circ. The right side was okay. You can see like some mild irregularity in the RCA, but nothing significant. Okay, her LV gram, you can see significant hypokinesis or kinesis of the whole interior wall apex. Everything is down. Okay, hyperdynamic inferior wall. Can you go back to the presentation? So the CAT was done at 1723. Okay, so let's look at the quality measure and time-wise for this patient. So the patient's symptoms, chest pain start at 1425. First medical contact with the squad was like 1430. So within 5 minutes, did a good job with that. Patient arrived with normal pulse sinus at 1450. Her EKG was done at 1605. It took more than 2 hours to get an EKG. Okay, so we did bad job with that, but it's not uncommon. Patient with cardiac arrest, they have a delay. There's data from the NCDR was published in 2011, Duke, and they show that there's at least 25 to 30-minute delay in patient with post-cardiac arrest. But in general, the door-to-balloon time was still 84 minutes in those patients. The main reason for delay was intubation, and the other one getting access. Okay, and we had the same issue with this patient when I went back to her chart. She kind of got another episode of polymorphic VT. They shocked her again, another round of CPR, and she got intubated. Then she has severe hypokalemia. They give her some potassium, so that's all in the delay. But this is still not acceptable. Anyway, then the patient, after they saw the EKG and they saw the anterior STEMI, it took them like she was taken to the cath lab at 17:13. Okay, more than an hour to get her to the cath lab. Once she got into the cath lab, just 10 minutes getting access. Once she arrived at the cath lab, getting access wasn't a big issue. The lesion was, the wire was across the lesion at 17:32, and the balloon was lit in 42. So they did a good job in the cath lab once the patient got there. But how did we do? Look at the guidelines. So if you look at the 2013 STEMI guidelines, you can see in the PCI capable hospital, the door to balloon, the first medical contact to intervention, door to balloon time is less than 30 minutes. Okay, in our case, it was 180 minutes. So we did a terrible job with that. And actually, even if this was a non-capable PCI hospital, the time is 120 minutes. Okay, so if you can see here, okay, 1, 2. So this is a 90-minute, okay, for PCI capable hospital, and here 120-minute within PCI. So we did a bad job in this regard. But as I said, this is not uncommon in patients with post-cardiac arrest for many reasons. The main one is intubation and the difficult access. But it's still 84 minutes. That's the at least what's the NCDR data showed. We did an echocardiogram, and Khalid, if you mind putting up the echocardiogram. And the same thing, I'll give you a minute to look at it. And then I go over it with you. Okay. So starting here, this is the parasternal axis view. This is your probe in the chest. the right ventricle at the top of the screen. This is the septum, LV cavity, posterior wall, mitral valve, aortic valve, okay? And this is the anterior septum, okay? And it's obvious if you compare the anterior septum, okay? This is the short axis. I gotta go slow. So this is the anterior septum, this is the posterior wall, okay? And if you compare these wall together, okay? The anterior septum significantly decrease in the contraction compared to that. And this is the short axis view. So the short axis view, this is the inferior wall compared with the anterior wall. Okay, there's significant difference between the contractility of the anterior wall compared with the inferior wall. So good contractility here, down, and this is the apical four-chamber view. So you're probably the apex. You're moving to two-chamber view. The same, and all anterior wall is not more severe hypokinesis of the anterior wall, anterior septum, and the apex. Okay, we can go to the presentation back. So kind of consistent with the angiogram finding. Okay, proximal LA, you have the anterior wall, anterior septum involved. Can we go back to my presentation? Thank you. So in the hospital, since she's post-cardiac arrest with no neurological recovery immediately, hypothermia protocol was initiated. She had setback with bradycardia, with sinus, hypotension, does not respond to fluid bolus. So we had to take her back. They had to take her back to the lab, put a balloon pump, and she was weaned for 2 days later. She was in epidural because that second episode of the VT, she got in the emergency room. She was extubated 3 days later. Her repeat echo showed improvement in her LEF. She still have mild hypokinesis, mainly in the anterior septum area, but EF was 50-55%. She has some memory loss and confusion post the event. The neurology was involved. Scan was normal. Her head scan, the EG was normal, and she was discharged home on the current medication: full dose aspirin, clopidogrel, metoprolol, lisinopril, simvastatin. 40 would not use. They did not use Lipitor because she had the intolerance to Lipitor in the past with myalgia. Nitroglycerin, and the neurology team started on the nabazole for that memory loss she had. Okay, so my question to you: what would you do different in this case? Okay, would you change her aspirin to 81 and use high intensity statin because this is acute coronary syndrome? Would you put an ICD because of cardiac arrest, it's shockable rhythm VT? Or would you do a stress test prior to discharge for that circ lesion? The official report, they called it the 80%. Okay, or would you do like FFR guided PCI to the circ lesion at the time of when they took her down for balloon pump insertion when she was hypotension? Or would you just do a PCI to the circ lesion the same time when she was in the cath lab post cardiac arrest? Would you just fix both lesions? So what would you do? Okay. So again, for people who joined us a little bit later, so we have a 61-year-old lady with sudden onset chest pain. She passed immediately. Squad got in there within 5 minutes. She was in polymorphic VT. They shocked her once, brought her to the emergency room. There was delay getting her EKG and take her to the cath lab. And the angiogram showed the thrombus, acute lesion, proximal LAD, 99%. Still there's like TIMI2 flow, and she also had significant lesion in the proximal circ as well. She ended up with bare metal stent to the proximal LAD, and the circ was not done. So, and now we're the question: would you just change her medication? Would you put an ICD because of the cardiac arrest? Would you do a stress test before discharge to see how significant that circ lesion? Or would you feel, if it was you, would you just fix the circ lesion at the same time when they opened the LAD? Or would you do FFR guided PCI to the circ when they took her down for the balloon pump because of the hypotension event she had? Okay, can we, okay, I think let's see. Okay, so most people recommend to do the aspirin and the statin, which is appropriate. But I said like she has intolerance to statin, to Lipitor in the past, but still not wrong answer. And The most of the audience, they think we should have opened her PCI at the same time with the circ when we did the LAD. And remember, was 2011, okay? So and that's kind of the main reason I present this case. So we can go back to my presentation. I think it's obvious everyone know she's not qualified for ICD because this is primary VT-VF. If you correct the underlying cause, no need for that. Okay, so this is the topic that we're going to touch base quickly today. Okay, so as you know, STEMI in the setting of multivessel disease is not uncommon. 40 to 65 patients who present with a STEMI, they had other significant lesion. Okay, but the problem, there's like mixed data. Okay, most of them are observational study, meta-analysis, and they have mixed results. And I'll show you that whether you just do the infarct-related artery PCI, the culprit only, or you do complete or preventive PCI. As most of you know, there's landmark trial, the BRIME trial. It was the first one who randomized patient to complete or preventive PCI versus culprit only, and they found there's 60% relative risk reduction in MACE. Okay, over the mean of 2 years. We'll go over that study quickly. Okay, in the future, BRIME was a small trial, so in the future there's like several trials going on. The main one is complete trial, it's a big one. I'll touch base on that once I have a slide for that too. So in general, what's the approach for patients who had STEMI in the setting of multivessel disease? So there's 3 approaches. Okay, the first one, what you do, what the BRIME trial, culprit, and dynamitry, they recommend you fix everything. You're already there, let's fix it and done with it. Okay. The other one is staged PCI procedures. Okay, and that's what the guidelines more recommend, or they can have soft recommendation for that. You fix the culprit lesion first, and if you want to fix the other lesions, you need to have functional studies or evidence of ischemia, whether spontaneous chest pain or positive stress test. Or the other conservative management, you just fix the lesion, the culprit, put on medical therapy, or if they have spontaneous symptoms, you bring them for that to open that lesion. Okay. So these are the 3 approaches for this setting. What's the disadvantage of each of these? So if you're talking about the culprit only PCI, okay, it has less incidence of peri-procedure complication. Okay, you know, you have a STEMI, you have angry vessel, high thrombogenic state. You just want to get them in and out as soon as you can. Things can go south any minute. Okay, so you need to be careful. But the risk, you're not fixing everything. You're leaving unstable lesion. There's like area of myocardium still in jeopardy of ischemia. Okay, so we're taking that risk. The other option of doing the multivessel PCI, fix everything, you already do it, you're already there, it's more convenience. If you ask the patient most likely to say do it once and for all. Okay, but the problem with that, more contrast, more risk of contrast-induced nephropathy, more radiation, there's procedure risk increase as well, and the same thing, more metal, more stent thrombosis, more complication, you're putting more stents. Okay, or the other option is the staged PCI, you fix the lesion and then you bring back the patient, whether you do it with FFR or functional study perfusion, that can help you too, okay, to see how that lesion is significant or no. Okay, but that's one, we're not certain when you bring them back. Is it bring 2 days before discharge, 1 month? We don't know that. Okay, and that's so this is a nice paper, Kim et al. In 2014, and what they look all the literature, all observational studies, okay, that tackle this topic, the STEMI with multivessel PCI, did not do any meta-analysis. Okay, and if you can see here, the top 5 studies, okay, they show that if you do multivessel PCI, this won't affect the outcome, the clinical outcome. I'm talking about MACE, okay, big outcome like mortality, reinfarction, okay, and MACE. So, and if you look at these studies in the middle, okay, what they find out that the opposite, okay, multivessel PCI is superior and improve the outcome. Okay, and down the road, down the list, these last 3 trials, they shown if the stage PCI is more superior than the multivessel PCI. So we have conflicting data. When we have conflicting data, what we do, meta-analysis. Okay, this is a paper in 2011 in JACC. Okay, 18 studies, 40,000 patients. 4 of these studies are prospective in the top, 14 retrospective. Okay, if you look at all these studies crossing the line of unity, we don't know. But the author concluded that multivessel PCI was associated with highest mortality rate, 60% risk, both short and long term. Okay, So here's another meta-analysis. 19 studies this time, 61,000 patients, 2 prospective, 17 retrospective. Okay, the same thing across the board, everything. Okay, some studies favor the culprit vessel PCI only, some support the multi-vessel PCI. What the author concluded that compared to culprit PCI, multi-vessel PCI compared to appears to be safe, and so with 33% reduction in mortality, 43% reduction in repeat PCI, and 53% reduction in the referral of those patients to CABG. Okay, which one would you believe? Okay. Guidelines 2013, as I said, this patient was seen in 2011. Okay, but the 2013 guidelines, okay, for STEMI, there's a class 3B recommendation to PCI should not be performed in non-infarct rated artery at the time of primary PCI in patient who is hemodynamically stable. So unless patient is in shock or you have multiple lesions that you cannot localize on the EKG, I don't know which one's the culprit, the guidelines recommend not to do it. Okay, just fix the main artery and it out. However, which patient they do, apart and hemodynamically stable, I said if they're in shock, you don't know which lesion is causing their hemodynamic instability, you can do that. But if they're stable, the only indication with the guidelines now, if the patient's having recurrent spontaneous symptoms, okay, or if they have, excuse me, or if they have positive stress tests, and that has to be intermediate or high risk feature on the, most likely would be perfusion scan, okay. The problem after they published the guidelines, okay, in September, the BRAHMI trial came. It was a big thing in the European Congress at that time. It was just few months after the ACCHA released their STEMI guidelines. And this is basically a randomized trial. It's UK-based trial, multi-center. They have 5 centers involved for 165 patients. And the study was basically looking at the difference between culprit vessel PCI, okay, versus multi-vessel PCI. So it was 1-to-1 randomization, and they look at the any non-infarct artery more than 50%. So that's kind of soft indication here, okay? And they exclude all left main, LAD, and CIRC, and patient who had history of CABG, and so basically any patient who's candidate for CABG, then do them, okay? They looked for the all-cause mortality, recurrent MI, refractory angina. And they follow up those patients for 2 years, 23 months. What they find out, there's a 65% risk reduction in the need for revascularization and trends toward lower incidence of cardiovascular death. And this was mainly driven by repeat revascularization, okay? This study was terminated early, okay, because of the significant improvement. And if you look at the Kaplan-Meier curve, if the preventive, the multi-vessel PCI, the blue line here, they have less, okay, better outcome and less event comparing with the with the just culprit artery with odds ratio is 0.35, and this is follow up to 36 months. So their conclusion was PCI to non-culprit coronary artery during primary PCI for STEMI reduced the risk of adverse cardiovascular event. However, there was limitation for that, okay? BRAHMI trial got a lot of heat, okay? So what they're saying, this is only for almost 500 patients. This is small to kind of hit strong outcome endpoint like death and MI, okay? So it was not powered enough, okay? The patient, the control group did not had any stage PCI, so and even a stress test. So as I said, the preventive or the complete revascularization, they get fixed in the index procedure. The one who get control therapy, just medical therapy. They do not do any functional study in the future. Just let them go on the medical therapy. Okay, it would make sense that if you see significant lesion, you will do a stress test. So they didn't do that. And the other thing I said, the 50%, it was soft indication for significant lesion. You know, there's significant variability. How many times, like in the cath lab, you see a lesion, you see it's 80%. Your staff, if they're in good mood, they want to fix it. They say, oh, yeah, this is 90%, let's do it. Or sometimes like they don't want to do it. They said, are you serious? This is like 50% lesion. Okay? And it depends if they're wearing their glasses or no. So it depends. Very, very kind of subjective, okay, when you fix this or no. And the pre-termination of the trial, this is kind of tricky part because sometimes maybe this is the period in the trial that shows significant difference between the two groups, okay? So if you continue following those patients, maybe the Kaplan-Meier curve, they kind of come closer to each other. So we don't know that, okay? As I said, then And the next year in the European Congress, again, another UK trial. It looks like the British people like very anxious. They're impatient. They want to fix everything once they see it. They cannot resist. But anyway, so this study was a smaller, okay? Again, multi-center, UK-based, 296 patient. And it's one-to-one complete revascularization versus infarct-related artery. But what they do different compared to the primary trial, okay? So they said, okay, the primary trial, they did everything during the index procedure. For them was during the index hospitalization. 1/3 of those patients in the culprit trial were done during the index procedure. They did the primary, the infarct-related artery, then they bring them back, okay? The other thing, if you look at the inclusion criteria for the primary trial, they excluded a lot of patients with the anterior MI, and those patients had worse outcome. Okay, the proximal LAD, ostial, and they randomized patient after they fixed the primary lesion. In the culprit trial, what they did, they randomized patient based on anterior STEMI versus non-anterior STEMI. So the anterior STEMI was included, and they randomize them immediately once they get the cath lab. It's not like after you fix the lesion. Once you see this patient had pre-vessel disease and sitting with STEMI, you randomize them on the phone. They pick up the phone, they randomize them. They go for complete or culprit artery. Okay, so technically they try to avoid all the limitation of the PRAMI trial. But they got very good results. So they look at the endpoint was the same, MACE and repeat revascularization in 12 months, and across the board, okay, the patient or the patient who included in the complete revascularization, they did better, okay, in terms of recurrent MI, repeat revascularization across the board, okay. And if you can look here, this is the yellow line, the complete revascularization group at 12-month follow-up. Only around 9% of them they meet the endpoint, okay, composite endpoint, comparing with the just preventive or the culprit artery, okay, around 25% of them at 12 months they meet the endpoint, the MACE, okay, with odds ratio of 0.45 with a significant p-value of 0.0009. So the author concluded that in patients with primary PCI with multivessel disease, index admission, so it's not the index procedure, okay, complete revascularization significantly lowered the rate of the composite primary endpoint at 12 months compared with treating only the culprit artery, the infarct-related artery. Then just recently, late 2015, August, exactly the time I saw this patient again, then the NAMI3 trial came out. Okay, it's Danish trial, and what they do, it's a bigger number. Again, 627 patient, multi-center trial. What they did now that something did not do. So one thing I mentioned, the culprit trial, they used 70% for significant lesion, but if you're using 50, it has to be in 2 views. Okay, so they're kind of better because I said the culprit trial was mainly 50% lesion to call it significant. So what they did, they randomized patient to get complete revascularization using FFR guide. So if you see, let's say, if you have an LAD disease anterior STEMI and you see significant circ like our patient, you fix the LAD, then you wire the circ lesion. If it's significant, less than 0.8, you put in stent, you intervene. If it's more than that, you let it go. Okay, so it's kind of using more functional stat. I know how much that accurate when in setting of STEMI, a lot of edema, significant. It's very hard to assess for that, but still better than visual assessment. I think all of us, we agree on that. So it was 1-to-1 randomization. They exclude all unstable patients, cardiac shock, because the guidelines support to do PCI, multivessel PCI for those, and any patient who need CABG, so left main disease, okay? And the primary endpoint was, again, MACE and repeat revascularization. They follow up those patients almost 3 years. They found that there's 44% risk reduction in the primary endpoint. And again, if you look at the patient with the complete revascularization, they did better compared with the patient with just culprit artery PCI with hazard ratio of 0.56. P-value was 0.04. And across the board, the same thing. They meet the primary endpoint. Those patients did better. They actually did something even interesting. They look for safety. You know, like as we said, you're using more radiation, more contrast. So they look at the safety issue, bleedings, and contrast in nephropathy. There was no big difference or statistically difference between both groups, whether you do the culprit or the multivessel PCI. This is a nice paper from Debeki and comparing both all these trials. Just for the sake of time, I'm gonna kind of skip it very quick. But You see Brahmi, so relative risk reduction 65, culprit was 53, and Dynami 3. The Brahmi was index procedure, the culprit was the index admission mainly, and Dynami was index admission as well. The Brahmi was 50% lesion, the culprit bit better, 70% with two view on the 50, and the Dynami used FFR guided. Okay, what's in the future? So now after those trials, what changed? The ACCHA with Sky, they have update for the guidelines, and they upgraded the class 3 recommendation for multi-vessel PCI in the setting of STEMI from class C harm to 2B. Okay, you may consider that. Okay, so that's kind of based on these three big trial. Okay, it's going to be like 2A or 1, we know, but hopefully with the future randomized trial will change this. So if you can look, the complete trial will be released in ACC 2018. Basically, they're gonna try to randomize almost 4,000 patients, and all of them has to be within STEMI within 3 days, 72 hours. Some of them will just get the culprit vessel PCI with medical therapy, and the other group will get the culprit vessel PCI. In addition, they will bring them back for index procedure during the hospitalization with FFR, and if it's this Desmond 8, they will intervene on that. Okay, they kind of try to hit hard in point mortality and repeat vaccination follow-up supposed to be 5 years. So let's go back to our patient. So she came back a month later. Okay, asymptomatic. She's doing well. This is a note from her cardiologist. Okay, he said she had a residual disease, 80% the proximal circ with minor disease in the RCA. This will be managed medically. Okay, so he's not planning to do any stress. She's doing well. So if it's not broken, why fix it? Okay, he would continue the Plavix for 1 year. That's her EKG, as you can see, complete resolution of the AC segment elevation, no Q wave, good result. Okay. Now, 1 year follow-up, she came back again asymptomatic. She's exercising. Excuse me. She's stable, and she's still on full dose aspirin, Plavix, metoprolol, lisinopril, simvastatin 40, and recommend follow-up 6 months. That's her cardiologist, not exactly. Okay, his assessment of that. So if it was you, what would you do at this 1 year post PCI, post STEMI, ACS? Would you stop the Plavix, continue the Plavix, or you don't know? So we can take answer for this. Can we take the poll? Yeah, thank you. Okay. So all over the place, okay? Some people, 25% will stop the Plavix, and 37 will continue it, and some people don't know, okay? Okay, can go back to my presentation. So across the board, this is a very controversial topic. That's why I want to kind of touch base on that. So as you know, this kind of topic has been like the pendulum been swinging back and forth. Okay, so some thought, okay, the shorter is the better. Let's stop it early, especially patient with high risk, and we have data about that. On the other side of spectrum, some people or researchers are being studied for longer duration of antiplatelet to prevent further episode of disease and stent thrombosis. So the shorter, and as you see, so it's up. If you're gonna plan to continue to do antiplatelet therapy, you're decreasing risk of ischemic stroke. We have evidence with that, but that's on the price of the bleeding. So it depends on you what price you pay for that. Okay, you agree with that? And my next slide. So there's several trials on this. Okay, the italic rest trial and the excellent, the one on the left of the screen here, they were mainly the shorter duration. With the second generation stent, drug-eluting stent, I think we do better. And there's risk of stent thrombosis. Okay, so it's safe to do this. Okay, the other spectrum, and mainly I'm going to pay attention to the DAPT study. Okay, this is the largest and the only study, okay, that's kind of meant or to answer this question for once and for all. Okay, the study was designed. The FDA was also involved in designing the study because they want to know what's the optimal duration for dual plate therapy on those patients. Okay, they randomized patient 12 months versus 30 months. Okay, Plavix and Prasugrel in addition to the aspirin versus just aspirin. Okay, and there was significant reduction in the cardiovascular event, ischemic event, and the longer duration, the 30-month group. Okay, comparing with the 12-month. But okay, there's few things on this study. Okay, there's the risk of moderate bleeding was higher. There was significant selection bias. Patient with high risk of bleeding and high risk of stent thrombosis, they were taken out of the trial. Even though patients with bare metal stent were involved in this trial, when they released the study in New England Journal of Medicine, they were not the calculation or the analysis was not included. They did not include those patients, and they found two things: there is increased slight risk of mortality in the patient with longer duration of dual therapy. The author from Brigham Women, they were saying because those patients they have more cancer than the other one, and the other thing they found something interesting within the first 3 months after you discontinue the dual therapy, there's significant increase in the ischemic event in both groups. Okay, so that's give us the question. So what's the optimal duration? So what happened after 30 months? If you stop it, the risk is there. So it's kind of catch-22. Okay, as I said, I think it's a shared decision between you as a physician and the patient. They need to understand it depends on the risk of bleeding. Okay, so if they have risk of bleeding, you will go more with the shorter duration. If they have low risk of bleeding and they have more risk of thrombosis or developing future episode, I think the longer duration you can make case of that. Okay. This is another meta-analysis that Dr. Maria from Harvard, and they have almost 70,000 patients enrolled from 14 eligible randomized trial, and what they find out, their conclusion was extended duration of dual antiplatelet therapy was not associated with difference in the risk of all-cause mortality or non-cardiovascular mortality with aspirin alone and shorter duration. Okay, the cardiovascular event is less, but does not affect the mortality. Okay, and the bleeding was higher. So now this patient came when I saw her. This is when I saw her. She came in August 2015. Now having dyspnea exertion, 3 months. She having chest pain and exertion, very typical for angina. And notice that's her EKG. So as you can see, sinus, no evidence of ischemia or ischemic changes here. Okay. I'm gonna skip this. This is her past medical history. Exam was unremarkable. So what would you do next with this patient? You have now she's a 64. She's come back dyspnea exertion and chest pain. Would you increase her metoprolol? Would you add Imdur? Would you do a stress test exercise or pharmacological with Alexi, or you do the angiogram? What would you do in her case? And we can take a poll for that question. Okay. So most people will do a angiogram. Few people will do a exercise stress test in the Lexi scan. One patient will add Imdur. I'm not sure if adding Imdur, this is like new onset angina, talk about unstable angina. I think going the angiogram is reasonable, and I would do that. But what we did in this patient, we can go to the my presentation. We did an exercise cardiolite stress test. Okay, so this patient, she walked for almost 5 minutes, achieved her target heart rate, and she stopped because of dyspnea and fatigue. Okay, good response. I'm going to show her EKG. This is her resting EKG. I'll give you a second to look at it. Sinus rhythm, no changes. Okay, just for sake of time, I'm going to show you the significant one. This is stage 1, nothing significant. Okay, her heart rate started picking up at 70. Stage 2, she achieved 129, but you can see sinus tag. She's having like lift bundles kind of morphology. And in recovery, still the lift bundles morphology, sinus. Okay, actually, if you can, excuse me. If you can also note, she start having evidence of AV block. Okay, look at the PR interval here. Okay, increase significant PR interval. Okay, now this is 30-second in recovery. You can see now having ST segment depression, elevation in the inferior lead, reciprocal changes in lead 1 AVL, and also there's ST elevation V3 to V6. Okay, and she has 2-to-1 AV block, so she start having AV block too. Okay, this is a bad sign. Okay, this is 1 minute from in recovery. Again, she still have persistent ST elevation in the inferior lead. Now the AV block improved. Okay, but she has still reciprocal changes. Looking at her, this is like 9 minutes. Looks completely normal. And this is her myocardial perfusion images. So for people who are not comfortable or not used to the reading Lexi scan, okay, this is the short axis, the rest, the stress on the top, rest at the bottom. This is the vertical long axis at stress, and this is down here at rest, and this is the horizontal long axis. Look at the stress on the top and rest at the bottom. Okay, I'll give you a minute to look at it, and I have more question, or maybe for the sake of time, I think I'm gonna skip this question. So you can see here, okay, there's significant decrease in the uptake in the inferior wall. Look at the wrist, okay, normal, almost normal perfusion in the inferior wall. But during stress, you don't see any uptake in the inferior wall, inferior septum, even some part in the lateral, okay? And remember her angiogram, she has right dominant system, okay? Here, there's another one in the longitudinal long axis. You can see there's no uptake in the inferior wall compared with the rest. So if we can show the last angiogram. So everyone agree, right? This is looks like RCA territory, but how about that circ lesion? Okay, like when we saw her, we thought, okay, this most likely circ lesion. Okay, and I'm gonna lay the angiogram for you again. Now this is radial approach. You can see the diagnostic catheter. And just leave it play them. Oops. Okay, significant lesion, okay, in the RCA. That goes with the EKG changes, the AV block, the ST elevation, okay, and the myocardial perfusion images, okay. So LV-gram showed normal pump, okay, and I go over with you over this. So you can see here, this is RAO view shot, left main, this is diagnostic catheter. You can see the circ, okay, going this way, and this is the OM. And you see, that's what looks like 90 or 80% in the previous study. It doesn't look that bad, okay? Still kind of tight. And here you have instant in stenosis, that proximal bare metal stent that we saw, okay? That was like 3 years later. Usually most instant stenosis occur like in the first 6 months, but she had. I think that's kind of very clear in this view. Another shot here, you can see the instant stenosis, like 80-90%. The spider shot, you can see the circ lesion is not that significant here compared to the previous one. And this is the money shot, okay? Hanging by a thread. Mid RCA, you don't see any contrast, okay? Barely one or few RPC going, okay? We can go my presentation, Khaled, please. Thank you. So basically, now this is the official report, right dominant, left main was normal. There's 80% instant stenosis in the LAD. They call the circ 40, 50. You can argue that, I guess. And the RCA was 99% hanging by thread in the proximal RCA. So this patient, because of her diabetes, she has proximal LAD with other lesion, 2 lesions. So she ended up with a cabbage. Personally, I thought she's going to go treat cabbage, but the surgeon did not feel the circ was significant as well. She went up LEMA to LAD and SVG to the RCA. She has an uneventful hospital course, went back home on aspirin, metoprolol, Lipitor. Now we give her another try for that, metformin, levothyroxine. So the take-home point, like, as you know, apart from the patient encouraging shock and in patient with continued ischemia after opening the carpet lesion, performing PCI to non-carpet lesion is generally discouraged, okay? As I said, even now it's class 2B, okay? And the stage PCI approach based on symptoms or evidence of stress test is a class 2A recommendation, which I think very reasonable, but one we still don't know, okay? And dual therapy is recommended only for 1 year post-definite ACI, regardless of stent type. But remember, all those trials I showed you regarding longer dual therapy, they were like drug-eluting stent. This patient, she had a bare metal stent, so even the whole discussion rationale is not like as strong. You still can argue you're giving the dual therapy more than 1 year is not for stent thrombosis. It's actually to prevent the progression of disease. You can make that point, but I want to make sure you understand this patient ended up with drug stent. I think that's the end of my presentation. Thank you so much for your time. If you have any questions.
Ayman, thank you very much. Very, very nice presentation. Really nicely done. So while we're just waiting for any questions, so if you want to ask any question, please raise your hand or just type your question in the chat box. what we'll do is I think, I'll start with asking one question. If
Sure,
you,
sure.
since you know what happened with the patient now, retrospectively, would you done anything different?
Retrospectively, I would do with her first STEMI, I would do a Lexus scan perfusion, like stress test before discharge. Okay, this is like, because at the time the guidelines don't recommend it. So at least, if not going to bring her for stage PCI before discharge, I'll do a Lexus scan, and if that was positive, I'll fix the circ at the time. That's what I would do differently.
I think Fathi was asking is what stent did the patient have in the circumflex artery?
No, she did not get any stent in circ. Was the LED, was bare metal stent integrity. Okay, it was like 18 to 3.
So it was bare metal stent, Fathi.
Bare metal stent. As I said, like the policy in our center, any patient post cardiac arrest, we don't know their history, we don't know the insurance. By default, they get bare metal stents, especially like a good size stent, short stent. So
there was another question, Ayman, is from Mu'taz. Is did you do both nuclear test as well as exercise?
So you know, anytime when you do a stress test, we would like to do an exercise. We would like to walk the patient so that gives us more prognosis, their functional status. In her case, with her prior MI risk of, we kind of felt more to do the perfusion image. So she got exercise cardio images.
I see. Okay. There was also, Ayman, a question earlier by Dr. Adil Al-Dayoub. If the culprit lesion was not LAD, with this patient's presentation, would you consider stage cabbage as an option?
Stage. So you're saying, let's say, you're saying, for example, like if her culprit was the circ, okay,
yes.
and you saw a significant LAD lesion, okay,
yeah.
would you do a staged cabbage? I think that's so the whole thing why the bridge start with this culprit and the primary trial, okay, was it's not with the LAD lesion as a culprit. When they see the LAD lesion as a culprit, it's easy. They fix it. Okay, they will deal with the RCA or the circ later on. It's not a big, but where they struggle when, as I said, as Dr. Adel mentioned, when the LED is not the culprit, you have RCA culprit or circ, you fix them. Now you're having proximal LED lesion. It looks kind of tempting to open it, and you're having a large AF myocardium at risk. Would you feel comfortable and let it go? And that's why the BRAMI, when they excluded most of the interior MI and the culprit, they try to avoid that. Okay. So if you fix the non-LED culprit, okay, it's hard to do a staged cabbage, okay, if it's like proximal LED, because it's not like left main equivalent, okay, right? Because you fix the other lesion, okay, but with the, so now it doesn't qualify to go for cabbage. And if you get my point. So now this patient, she went for cabbage now because she has proximal LED with other significance. She had 2 vessel disease, one of them is proximal LED, and she's diabetic, so she will do better. But I think doing the stage PCI, I wouldn't have a hard time for any interventional cardiologist to send this patient for a staged cabbage, especially post cardiac arrest, and she's having like neurological symptoms after that. I'm not sure if any surgeon would be excited to take her at that time. But if the case was left main, the non-culprit, you see significant left main proximal LED, and she's diabetic, EF is down, that's very reasonable to consider cabbage. Yeah. In our center, we have very low threshold to refer patient with cabbage, but I don't think this will be one of them.
I think I am excited that we could see that Adil, one of the cardiothoracic surgeon in Canada, and Fathi, who is one of our consultant interventionists in the US. It looks like, can we give Adil, we'll give Adil the mic to speak. So we'll just change it to, okay, here you go. Adil, the mic is yours. Adil, we cannot hear you. You may need to enable your audio.
You hear me?
Yeah, we can hear you now.
Okay. Excellent presentation, Ayman. Was really a nice review of the topic. Just a quick comment just before I proceed further about the role of cabbage. I think my question was initially if, I mean, I do see this very often when, especially when the inferior STEMI, when they fix the RCA, and there's always like a multivessel disease, as you said, and a lot of significant proportion of people coming with the STEMI, they have a multivessel disease, and most centers tend to fix the culprit. And I do get these calls probably 3-4 times a year where, oh yeah, we fixed the RCA with 2-3 stents, and could you see this patient in 6 to 8 weeks to consider doing the DIAG, the LAD, the CIRC, which are 70, 80, 60%. I think in your case, when I asked you the reverse, if you fixed the CIRC and you left with an osteal significant LAD, I know it's not a left main equivalent. I think osteal Brock's LAD, osteal or Brock's LAD is still considered best served by Lima. I think in centers like our center where we offer a minimum invasive cabbage, Lima to the LAD, if you're a cardiologist, I think they have a surgeon who could offer this as an option. This is where probably one of the areas of hybrid vascularization. I've done probably 2 or 3 people either stage before. I prefer to do stage surgery first, but in your case, you might be forced a little bit to wait until you stop the Plavix because you need to have a good 2-3 months where the stent is covered and matured, and so you don't run the risk of losing the CIRC. But I think hybrid Lima to the LAD by a 5 centimeter thoracotomy is an option in your case. I think
No, I think that's yeah, no, absolutely. I totally agree with you. And I said the problem, as you said, when the LAD is not culprit and you have like very proximal LAD, this is the I think I said our center have very little to show to refer for cabbage because we do believe patients with Lima, they do better than any stent we have. I think the best stent we have is the IMA, but we don't do mini invasive cabbage. We have a great surgeon, but he's kind of old school. We don't do this, but I think that's very, very tempting option, especially in the future, and hopefully we see more and more of this.
I mean, I think we'll see, we'll value Fathi input. I think Fathi wanted to take the mic. Fathi, do you, the mic is yours. We'll value your input, and if you have any questions.
Assalamu alaikum.
You may need to lower your microphone.
Can you hear me?
Now it's much better.
Okay, I'm sorry. Is this clear, Khalid?
Can you lower the volume?
Can you hear me?
So, mute yourself.
Can you hear me? Sorry, Ayman, nice presentation. I missed the first part. I was in and out. I'm on call. Question: Did the patient did not get a drug-eluting stent? Is it because you don't know what's her insurance status?
Yes.
What's
so
the
I
reason
said
for the patient not to get?
Yes, so any post-cardiac arrest, we don't know their bleeding risk, their history, their insurance status, and compliance. If they're post-cardiac arrest, they get by default bare metal stent. And especially in her case was proximal LAD, okay, large size stent was short, so, but that's kind of more the operator preference, okay, because we have a lot of patients,
Okay.
the area where our hospital at, a lot of patients with issue with compliance insurance, so we commit them to a drug-eluting stent. And remember, this is 2011. Okay, we have a lot of issue with the bleeding and stent thrombosis because of the compliance. So that was the main reason for bare metal in her case.
And for the CIRC, I missed the part. So the CIRC also was given bare metal stent?
No, that's so that's the discussion. So the CIRC was not intervened on, and that's why we're talking about the STEMI and the multivessel PCI. So the option whether you just do conservative treat or do stage PCI or you need a stress test. So that's so in her case. Her cardiologist did not intervene in the CIRC, and she was doing well clinically, okay, and he didn't feel that even she needed a stress test, perfusion study. So, and she did well till I saw her 3 years later when she had with this new onset angina, and we thought, okay, this is the CIRC, okay, so we did a stress test, and came back the inferior wall. You saw, I don't know if you saw the last angiogram.
No, I've seen the part. I've seen the stress part and the MIPI scan. So the circ lesion was not significant. Did they feel it significant or not significant?
So the initial one, they called person. They feel it was significant. They did not intervene on it. And I said, in the setting of anterior STEMI and cardiac arrest, they did not intervene on that. And she did not get like stage PCR. And clinically, she was doing better. So no one felt that you need to fix her.
So let me tell you. Right. So let me tell you what my bias about this case. So this is somebody who has a LAD lesion treated with bare metal stent, somebody who's diabetic, and has a 3 years later has a lesion in the RCA on a stress lab and proven to be significant. And now she has 2 vessel disease and the circ. We don't know the significance of that. I didn't see that. Did they do an FFR for the circ or anything to evaluate the significance of that? No, probably not. So I can't hear you, Ayman.
No, not FFR. They called 50%, and even the surgeon did not bypass it. She just bypassed the LAD and the RCA.
So we have somebody who has a 2 vessel disease. To me, from the interventional standpoint, the lesion in the LAD and the lesion in the circ, if you calculate her syntax score, it's going to be low. A syntax score is going to be definitely less than 21%. And this will put her in the category of equivalent risk for both intervention and bypass surgery. I think this lady is in her 60s, correct? The appearance of this lesion 3 years later, and the LAD lesion, what I would do, honestly, I would just do an OCT for that LAD lesion and understand better the mechanism for in-stent restenosis. If it's an in-stent restenosis, like neointimal hyperplasia, and then this lesion looks very focal. It's not ostial LAD. It's a proximal, but not ostial yet. I think there is still rim in that proximal part. I would go with the drug-eluting stent there. After now, the patient is awake, so I can discuss this with her. If she can afford dual antiplatelet therapy for at least a year or so, even on compassionate basis, and then I would just offer her 2 stents. Both of them looks like slam dunk. The RCA lesion is focal, short, slam dunk, and so is the LAD lesion. I would just do 2 stents for both lesions. Maybe you do FFR for the circ just to assess the significance of that, and leave her alone. This would be my approach for this. 2 focal lesions, and again, this is all if the patient is able to afford dual antiplatelet therapies.
She's diabetic.
Yeah, regardless, I mean, this is again focal disease, very focal lesions, and if it's we know that drug-eluting stents, you're not comparing her choices. You didn't give her the best choice, which we have now, which is drug-eluting stent. You treated one lesion with a suboptimal options, which is bare metal stent, and you didn't treat her against the best choice, which is drug-eluting stent. And the worst case scenario, she will be back with the in-stent restenosis, and you can give her, at that time, you can offer her surgery. RCAs, I mean, so, regardless, in fact, RCA is the easiest one to do.
Mm-hmm. Yeah, I know, I get you. So in what evidence the drug-eluting stent is better than the cabbage in those patients of the left main equivalent?
No, well, this is a 2-vessel disease. Remember, this is not a 3-vessel disease or left main like the Matrix or other studies. So this is, and most of the older studies, they compared surgeries versus surgery versus intervention. It basically goes back to old data. There's new data, correctly, but this is a low-risk patient for both. We know these patients will do equally well based on the syntax score. If you calculate syntax score, I can tell you right now, this is going to be definitely less than 21% for sure. It's going to be a low risk for both lesions. If you enter the circ in the equation, and then becomes a little bit more complicated. But it looks like the circ is not severe, so this probably make it unlikely.
I would be interested to hear Dr. Ayub's input about this, Dr. Fathi. But your point is well taken. I think it's very reasonable. I think there's no right or wrong what to do. It's the operator preference. And as I said, for us, two-vessel disease was it has left main equivalent, and diabetic, they do, I mean, strong data with the especially IMA to LAD, they do better. I just want to make a comment on one point Dr. Bartez and Dr. Ayub mentioned. Why we did perfusion study, since we know that her from the EKG, it's positive study, right? But remember, like when you do the exercise cardiolite, you take the resting images before you do the exercise. So we had the resting images. Okay, we do exercise. Okay, even if you saw that, okay, it will be just a waste to do the images, rest, and not completing the second part, especially in someone you know that they have RCA disease, and you show the inferior wall. It actually, even if you inferior lateral wall, some decreased perfusion there too. So is it like this RCA or even circulatory? So it's just like technicality. Why, if you were the one who supervising the stress test, and the patient already had the stress images, that you stop doing the stress images? You already give the Lexus scan, the vasodilator, and you already did the images. So just like, I don't see why you don't do it, because it's part. If this patient had just regular treadmill exercise, and that's what we saw, yes, no need for adding images. I agree with that. But because like this is how she was, I hope that this is kind of clarify the confusion. Again, I'd like to give Dr. Ayub about the input regarding the cabbage. And I'm going to excuse myself. I think I just take another 2 minutes because I got to go. And thank you everyone for taking time and listening, and thank you for your great input. Thanks, Dr. Fathi and Dr. Ayub.
Ayman, thank you very much. I know that you have to go. It's really a great talk and very good overview of the literature, and generated a lot of discussion. So Ayman, once again, thank you very much. Really, really enjoyed your talk, and I look forward for your future presentation. So I think now we have to move on because of time. I'm delighted to introduce our next presenter. He's a good friend of mine, Dr. Mu'taz Al-Khadri, consulting cardiologist and electrophysiologist in Liverpool Heart and Chest Hospital.
Hi, can you hear me now? Yeah? Good, okay. So each case will just have some information, then probably an ECG trace, and then I'll give you some multiple choices to choose from, and then we'll give the explanation and some teaching points. And I'll give you a few minutes if you want to ask any questions about each one of those cases. So without any further delay, we'll go to the first case. So this is a 78-year-old man admitted with paroxysmal atrial fibrillation. He was started on sotalol 80 milligrams twice daily, was admitted to the hospital for overnight just for observation, and was put on telemetry. They called you at 3 o'clock in the morning to review this trace, which was recorded when the patient was asleep. So I'll give you the ECG to have a look at. And then after that, I'll give you some choices on what you would do in this case. Okay, so here are the choices. So would you stop the sotalol? Would you do an EP study? Would you offer this patient an ICD? Would you check magnesium and potassium? Or would you just continue playing as you were doing at 3 o'clock in the morning? That we can have the poll. And I'll just take you back to the ECG again. Okay, have you got any results for us? Okay, good. So somebody who said they would stop sotalol, most would do like what I would do, which is basically continue playing Angry Birds. Excellent. Okay, let's go back to the ECG, please. Okay, so this is one of the sort of classical cases where this is all artifact. Okay, key to sort of picking up this trace is that you will find that if you can trace the RS complexes within the area of artifact. So that's a very important finding there, okay? And then the second thing is that the way the arrhythmia, or the supposed arrhythmia, terminates is that it sort of blends in back into sinus rhythm, which is not normally the way that arrhythmia would normally terminate. So normally when you have somebody with ventricular or atrial arrhythmia and it terminates, you frequently get a pause before sinus rhythm resumes because the sinus node has been suppressed for a period of time. The case, you would never have VF or polymorphic VT blending in back into sinus rhythm the way this ECG shows. The cases, you would also find that the baseline tends to be wavy. It's not the case on this ECG, but normally these are the clues that you have artifact. So the teaching point with this case is that always try to look out for artifact. It's very easy to get missed, and frequently patients get referred. You know, there are some patients who have been referred for ICDs just based on ECGs, which are very similar to that. And the keys to that is that the baseline normally is unstable. The QRS complexes can be traced within the area of an artifact, and it normally blends back into sinus rhythm, unlike real arrhythmia. And then a final point is that the rate has to be physiological. So anything which is faster than 300 beats per minute or less than 200 milliseconds, it's probably not going to be real. It's unlikely to be physiological to be real. Okay. And I've got some more examples here of these ECGs. So this is another one where again you can see that you can trace the QRS complexes inside the the area of artifact, and again that will show you that this is basically artifact rather than a real arrhythmia. Here's another one. This one is a little bit harder to tell, but you can see that the baseline suddenly changed dramatically. So you had a fairly stable baseline, then it all changes. And again, if you follow these, you'll find that there's one here, there's one there, there's one hiding probably there, and then there's one which is hiding. You can just about see it there. And again, the way it terminates, it blends back into the normal rhythm, which is unusual for real arrhythmias. And then finally, there's this one. Now this patient is having torsado point, but this is clearly artifact because the ventricle. This is ventricular activity. It's basically contracting so rapidly. It's contracting like every 40 milliseconds or so, and this could never be physiological. This could never be real. This is just too fast for it to be real. And this was run like normal speed. You can see it here. This is normal sort of heart rate, and then suddenly you lose contact with the ECG probe, and this is almost certainly sort of electrical interference with the lead sort of touching something. So that's the first case. So it's basically beware of artifact. Would you have any questions that you would want to ask about this case?
What else? I think there is a question by Dr. Fethi. Is this a halter?
This one, the last one?
Yeah, I think
this one.
It's
not a halter. This one was a telemetry, two-lead telemetry on the ward, and I agree with you. There's a change in the rate there, but this is not the issue. The issue here is obviously, this was called polymorphic VT / sort of torsado point. This clearly isn't that. The patient I think had sort of, I think was on CCU because she had episodes of atrial fibrillation, if I remember correctly. But the main finding where the patients came, the junior doctors came to me in the morning were saying, this is clearly sort of polymorphic VT, and this is clearly not polymorphic VT. So this was a telemetry strip from the ward.
Because I think, if I understand Fethi very correctly, his comment is about, for example, let's say, can you see my pointer there?
Yes.
Yeah. So he's saying that the artifact sometimes is fast, but then this look like slow, and then fast again. I think this is what you meant, Fethi. Okay.
Yeah, I mean, it doesn't matter. I mean, it's still artifact. I mean, there's no way this could be physiological. I mean, this is running like at 20 milliseconds. There's no way, there's no way this could be artifact. And this is not a battery-operated system, so this was like telemetry hooked up to the monitor. And I'm assuming that the lead sort of fell off or something. But the bottom line is that this is artifact. I mean, I don't know exactly why, what kind of artifact you're going to call this. but the main thing is really recognizing that this is artifact and this is not a real arrhythmia.
Absolutely.
Does that answer the question?
Yes, absolutely.
Okay, so we'll move on to the next case. So, a 72-year-old female admitted to the ward with infected exacerbation of COPD. She felt palpitation and the following ECG was recorded. Okay. So, I was on call on that day, and the junior doctor sort of came in and showed me this ECG, which doesn't look like a very healthy ECG. So I'll just give you a couple of seconds to have a look at the ECG, and then I can show you the options. So when you see an ECG like this, what would be the main thing that will come to your mind about this? I'll give you more information. I don't expect you to make diagnosis on this ECG, but I just want to see what sort of the first thing that jumps into your mind when you see an ECG like this. And I'll give you the options now. So would you think that this is an SVT? Would you think this is ventricular tachycardia? Would you think that this is an idioventricular rhythm? Would you think this is something metabolic, or just call it back? So SVT1, VT2, idioventricular rhythm 3, metabolic, either drugs or electrolytes number 4, or freaky ECG 5. And I'll take you back to the ECG. Okay, we go back to the presentation. I think that should be enough time. Right, do we have the results? Excellent, that's very good. I'm pleased to see that most of you answered the correct answer, which is, metabolic. So, and I think, most of you, I think on the chat were saying, it's a potassium problem, and I agree with you. It's probably sort of more in keeping with hyperkalemia. So this as actually, I mean, that was my first question: is what's the patient's potassium? Because this really looks very metabolic, and the potassium was normal, but the patient was on flecainide, and the dose of the flecainide was increased recently. So this is the kind of appearance that you get with flecainide toxicity, and this was a case that was quite freaky. I mean, when I went to review, I ran to review the patient, and the patient was quite stable. And then we stopped, after stopping the flecainide, her ECG just sort of spontaneously went back to the normal rhythm. So the question is, how would you then, the key management is, how would you treat patients with flecainide toxicity? And the first thing, obviously, is to stop the offending drug. So in this case, stop the flecainide. And a lot will depend really on how stable or unstable your patient is, and what's the circumstances of the flecainide toxicity. So if the patient has just suddenly taken 50 tablets of flecainide, your response is going to be, and presents with that kind of ECG, then your response is going to be different to somebody like my patient, who was already on flecainide and had a slight increase in the dose. So, the flecainide levels in her case are unlikely to go extremely high. Whereas if she's somebody who's taking 50 tablets of flecainide and then suddenly her ECG is like this, then you would worry that her levels are going to go even higher, and you have to anticipate that she's going to be hemodynamically unstable with it. In my case, I mean, we basically just stop the flecainide. Control the heart rate. This is an important one. So you always have to remember the flecainide has got something called rate-dependent use. So you get more antiarrhythmic effect out of the flecainide at higher rates. So that's why you almost never see flecainide toxicity in somebody who's bradycardic, and it's almost always in somebody who just is already on flecainide, but they go into an SVT or an atrial tachycardia. So one of the key things is that if you slow down the heart rate, you'll get less antiarrhythmic effect out of the flecainide. Flecainide is as a competitive sodium channel blocker. So basically, one of the ways of displacing it from the sodium channel is to give patients a sodium load, and you can do that by either giving them saline or hypertonic saline to try and displace the flecainide off the sodium channels. You can also, because flecainide is a weak acid, you can give them sodium bicarbonate, and the sodium bicarbonate will give you a sodium load, but would also neutralize and help solution of the flecainide. If you have a very severe acute overdose, you may need to consider hemofiltration, although it doesn't always get rid of the drugs, but it will reduce the levels to a certain extent. And there have been case reports where you've got very severe hemodynamic disturbance with it, and then you can use ECMO to try and, you know, buy the patient a couple of days until the drug is metabolized and gets out of the system. So the teaching points about this case is that always remember metabolic causes for a very abnormally shaped QRS complex. Okay. And my rule of thumb about this is suspect this when the nadir of the QRS and the peak of the T wave form a direct line. And what I mean by this is that if you look here, you know, the bottom of the P wave to the top of the T wave, it's pretty much like a straight line. And you can see it here as well. So always when you see this, think something metabolic, like as similar to what a lot of people have suggested, which is, you know, hyperkalemia, but also drugs in these cases. So some of these patients, you just have to review what met on. Case? Okay, well, if there are no questions, then we'll move to the third case. So this is an elderly woman which was admitted with ECG was recorded, and the question is, what do you think is going on here? This is not my ECG, so I'll give you about a minute or so to go through this ECG, and then we can go back and talk about this ECG, and I'll guide you on how, you know, electrophysiologists in general will go through a complex or a difficult ECG that is not very clear. I'll give you the choices and then I'll come back to the ECG again. So would you think this is sinus tachycardia? Do you think this is atrial fibrillation? Do you think this is atrial tachycardia, junctional tachycardia, or you're just not sure about this? So sinus rhythm, AF, AT, or junctional tachycardia. I'll go back to the ECG. Okay. We see the results. Excellent, very good. So let's go back to the ECG. Right, so this is an interesting ECG. So I think when you're faced with difficult ECGs like this, it's important to identify what the P waves and the QRSs are doing, and try to look at the areas of transition where there's something which is sort of perturbs the tachycardia. So the way I'd look at this is that this is predominantly a regular rhythm, apart from this area in the middle here. Okay. So then you're trying to find out what's happening with the P waves. Okay, and with the P waves, you can identify a P wave here. You can identify. Can you see my pen moving around? Yeah. Yeah, you can see it. Yeah. Okay. So there's a P wave which is hiding there, and there's a P wave which is here. My advice is that always try to sort of correlate the P waves with multiple ECG or multiple leads. And the advice that I would normally tell people is that always look for the P wave which in the lead which has the smallest QRS complex. So think of the P waves and the QRSs are like a needle and a haystack. So if you've got a big haystack which is the QRS complexes, and you've got a small needle which is the P wave, you would look for your needle in the lead which has the smallest haystack. So if you look at all of these leads, the lead which has the smallest QRS is going to be V1 in this case. And here I can see that this is the P wave. If I follow this up, then I know that this deflection is the P wave. And then if I follow this later on, I can see that the P waves are actually falling on the T wave, and that's why we're not seeing them here. So all of these have a P wave which is hiding inside the T wave. Okay. Now with this knowledge, I know that there's a P wave here, and I know that there will probably be a P wave there. So I've got a drop beat that does not conduct. There's no QRS after that one. And this is really the hallmark of what you'd see with Winkeback. Okay, so you've got a drop P wave. The PR interval before the P wave which is dropped is the longest PR interval, and the one afterwards is the shortest PR interval. And then the PR interval prolongs, and then prolongs further, and then you keep on going there. So this is a case of somebody who's got sinus tachycardia with Mobitz 1 or Winkeback. So the PR interval before the blocked P wave is normally shorter after the one shorter than the one after. This is very characteristic of Winkeback. So the diagnosis here is sinus tachycardia with Mobitz 1. And the teaching points here is look for the P waves in the leads which have got the smallest QRS. It doesn't work always, but it's a very useful tip. It's easier for you normally to see them in the leads which have the smallest QRS. Now that might not necessarily be the case if the P wave vector is sort of perpendicular to that lead, but most of the times it would be a useful tip. Use all the availables to find the P and the QRS and sort of correlate them with each other. The P waves can easily hide inside the QRS or the T wave. And finally, the Winkeback cycle length can be very long or even be very short. So in this case, the cycle for the Winkeback was very long. So normally we're used to like 3-4 beats and then you get a drop P wave. Whereas here, it's obviously like 7-8 beats before you drop a P wave. Okay? Anybody? Good. So we'll move on to case 4 in that case. So this is a young patient who was admitted with palpitations. The following ECG was recorded. So unfortunately, this is one of the hospitals give a long rhythm strip at the bottom. So you've got 6 leads here, 6 leads there. So what do you think is going on here? And let me just give you the choices. So sinus tachycardia, atrial tachycardia, AVRT, AVNRT, don't know. Okay, so sinus tachycardia, atrial tachycardia, AVRT or AVNRT or don't know. I'll show you the ECG again for a bit. Okay, I'll give you another sort of 20 seconds or so to have a look at this ECG, and then we can dissect the ECG a bit further. Okay, so sinus tachycardia, atrial tachycardia, AVRT or AVNRT or don't know. And if you can just vote there, please. And the question is, what is it most likely to be? Okay, can we have the when you can? Somebody said don't know. Okay, so let's go back to the ECG, please. Right, so it's not an easy ECG, but I'll take you through how we trace it. So the first part, the left part of the ECG is clearly sinus rhythm, and then there's a change in the rate. It's predominantly irregular narrow compression at the beginning of it, and this is not unusual. So, very often tachycardias, when they start, the beginning of it may be a little bit irregular, and that would probably apply to most of the SVTs that we know of. So now the question is, we need to try and identify the QRSs and the P waves so that we can try to sort of dissect this a little bit more. I'll show you just slightly a bigger ECG here, where I've blown up the sort of V1, because that's where you see most of your P waves. Okay, and then here you can see that there's a P wave there, there's a P wave here, there's a P wave here at the end of the QRS that dents the back of the QRS, and then they've got a P wave here, P wave there, P wave there, and then after that you get P wave pretty much at a constant space here. Okay, so what's happening here is that you've got typical Winkeback appearance at the beginning. So you've got a PR interval that gets longer, and then you drop a beat, then you have a short PR that's longer, and then after that it stops going. So it doesn't continue the Winkeback cycle now. So that would pretty much straight away rule out, for practical reasons, will rule out AVRT. Not 100%, but almost always would rule out AVRT there. And it will probably, it's not sinus tachycardia because there's a sudden change in the rate there. So differential diagnosis is going to be between an AVNRT and an atrial tachycardia. And the way it starts and the way it behaves is very, very suggestive of an atrial tachycardia starting there. So the fact that you've got more A's than the V's is probably more towards an atrial tachycardia than AV and RT, although it's not impossible to have that in AV and RT. But the way it starts is very suggestive of an atrial tachycardia, I would say. So the teaching points about this, so it's a narrow complex tachycardia, you've got more A's than V's. It can't be AVRT because AVRT is obligatory one-to-one tachycardia. And it's most likely to be an atrial tachycardia with initial Winkeback. So the teaching points about this is that always look for the P waves and decide if they are associated with QRSs. And always remember that AVRT is normally obligatory one-to-one AV conduction. So AVRT is normally obligatory one-to-one AV relationship. So it's very, very unlikely to be AVRT, and this is more likely to be an atrial tachycardia. So I've got a question: is why can't it be K-sign crossover? It could be. I mean, to me, the way it initiated and the way it's sort of, behaving in a Winkeback sort of pattern is very, very suggestive. As I said, you can't. I don't think you can 100% rule out AV and RT without doing further sort of pacing maneuvers on this. But in my view, the way it Winkebacks through is to me is suggestive, very suggestive of that. I'm just looking at the chat there. You probably have to be assuming that the relationships are sort of varying, in my view, very significantly there. You've got Winkeback sort of appearance at the beginning. You must be Winkebacking in the slow pathway with the varying sort of VA time with the varying PR interval. So it's not a very fixed sort of PR interval there. You may assume that this is going back a fast pathway, and then you've got a very short PR interval, which could be going down a slow pathway. And then what would this be what this one would be then? Just suddenly goes down a slow pathway. To me, it's, as I said, you can't 100%. This is why I said, what is it most likely to be? In my view, this is going to be almost certainly an atrial tachycardia, not 100%. I know you're suggesting there are two slow pathways. What is it more likely to be? Common things are common. Young men with a tachycardia with antegrade Winkeback pattern. It's almost more likely to be atrial tachycardia rather than AV and RT. But I said that at the beginning. I don't think you can tell for sure that this is not going to be AV and RT. You need, if you take this patient to the lab, you'll need to confirm this with pacing maneuvers later on. No, unfortunately, this is why I said I'm a bit annoyed with the hospital that does this trace, because they don't give you a long rhythm strip at the bottom, and it just happens to start exactly where the leads change. So I agree with you. If you've got like a negative sort of P wave, then you can sometimes sort of tell from the P wave morphology whether it's a retrograde P wave or not. It's very disappointing that some hospitals decide to put them this way, and I just don't see the point why they do that. And we've got a couple of hospitals in our region that do this, and we keep on telling them to stop doing this, but they never listen to us. So just looking at the chat, the last three Bs show some sort of VA unlinking there. Yeah, the PR interval seems to be the constant part here, rather than the VA, which I agree is more suggestive of an atrial tachycardia. Good. So let's go. Are there any other questions at all? Okay. Next case. So this is a 55-year-old man who's had a history of syncope, and he had 2 negative tilt tests. Nothing really remarkable on his ECG. So he had an implantable loop recorder placed in, and so these are the 3 traces from the loop recorder that I'll show you. So this is the first one. I'll just keep on flicking between the 3 so you can continue to see them. So this is the first one, This is the second one. And this is the third one. Okay, and I'll just take you back again to the first one. We'll go through them again slowly, and then I can give you the answers. So this is the first one. Second one. And this is the third one. So I'll show you the answers, and then we go back to the ECGs one more time, okay? So do you think this patient has got AV node disease? Do you think the patient has sinus node disease? Do you think the patient has both AV and sinus node disease? Do you think it's a vagal response, or do you think this is artifact? So the answers would be either AV node disease, sinus node disease, both sinus and AV node disease, vagal response, or artifact. We'll go back to the ECGs so that you can have another look at them. So this is the first one. Second one. And this is the third one. So they're going, this is the, you know, this logically follow each other. First one, and follows from there to there. And this is the last one, from there to there. Okay, do you want to vote? So AV node, sinus node, both AV and sinus node disease, vagal response, or artifact. Okay, and can we see the results? Excellent. So most of the people sort of agreed that this is probably vagal response. Okay, let's go back to the ECG and we can go back to them again. Right. So you will see on this that. So I'm pleased that, you know, the people sort of notice that there's a problem with sinus node and AV node conduction. Okay. So you can see here that the sinus node is slowing down gradually, and then you get the PR interval prolonging, and then after that you go and it's even prolonging further. The sinus rate is really slow now, and then you've got AV block, so you've got P waves here that don't have any QRSs, and then the patient falls and bangs his head on the floor, so you can see that clearly there. And then after that it starts recovering, and you can see the PR interval getting shorter there, and then it becomes really short and recovers. So I'd agree with you, there are signs of sinus node and AV node sort of being affected. The bit that doesn't really make any sense is that, normally speaking, when your sinus rate goes down, you'd expect your AV node to conduct better because it's, you know, it's had more time to recover. So this is not really following the regular pattern that we would normally see in real life, where, you know, the sinus node, you know, you're more likely to block in your AV node when your heart rate is much faster. Whereas here, what's happening is that as your heart rate or your sinus rate is going slower, your AV conduction is actually getting worse. And this doesn't really fit very well with just, you know, conduction disease defect. And this could really be explained by vagal response. You have to remember that the sinus node and the AV node are heavily innervated with autonomic nerves. And in general, the sinus node is more, you know, heavily innervated with autonomic nerves compared to the AV. So whenever you get vagal stimulation, the typical response, it's not always, but normally the typical response is that you would get a slowing down of your sinus rate because the sinus node has got more, you know, parasympathetic nerves. Then following that, the vagal stimulation reaches the AV node, so you start, and then you get, you know, your complete heart block or whatever. And then when it recovers, obviously the first bit to recover would be the AV node, because it will, you know, the sympathetic nerves kick in first there, and then after that the vagal stimulation will come off the sinus node, you know, last. So the normal response is that you'll get sinus bradycardia, then you get AV conduction being affected, and then the AV conduction recovers, and then the sinus, you know, sinus rate recovers after that. So it's really difficult to have a transient, simultaneous, happening at the same time. You know, I've seen patients who have sinus node disease who also have AV node disease, but it's very difficult for these things, just for both of them to happen exactly at the same time, and they happen just transiently. So they just, you know, before that everything was fine, and after that everything is fine. And for those like 3-4 seconds, you know, you've just basically both AV and SA conduction are not working very well. So The only real explanation for that is vagal stimulation. So normally speaking, the best treatment for this is not always pacing, and normally the guidelines would say your first choice is to go with lifestyle measures. Having said that, this is a gentleman who's had 2 negative tilt tests with no drop in the blood pressure during them, and he injured himself twice with his syncope. So we did end up having to implant a pacemaker into this guy. I did warn him that it may not completely get rid of the episodes, but it will probably make them, less severe. And we implanted a biotronic pacemaker with a CLS sensor, and he done really well. He hasn't had any further syncope after implanting the pacemaker. So this was one of the cases where probably it was one of those which were predominantly cardio-inhibitory rather than vaso-inhibitory response for his neurocardiogenic syncope and vagal stimulation. So he did well clinically, but normally, personally, I would delay implanting a pacemaker in these people and give them lifestyle measures. But we had 2 negative tilt tests, and we had evidence of injury to the patient, and the patient was willing to try anything to try and reduce the severity, if not get rid of these symptoms. Any questions there?
Mu'taz, just one question. Just for the audiences, we are very fortunate here. You could see the P wave in your reveal implant. I think it's if you don't see the P wave very clearly,
yes,
still you could argue this is still vagal stimulation. What's your thought about that? If you don't see the P wave,
I think you may be able to do that. I mean, when I implant my loop recorders, I'm actually quite fussy about sort of making sure I get I screen beforehand, and I screen beforehand, and I would to make sure I can see the best P waves. I agree with you. Sometimes you don't, but I think in this guy we were actually reaching the point that we were probably going to implant even if we weren't seeing P waves. Had a long significant pause. We were probably committed to implanting a pacemaker. He was willing to try anything to try and he was willing to try anything. I mean, in this case we had P waves, and the way it's slowing down is not typical of AV sort of node disease, and it becomes a bit more difficult when you can't see the P waves. We have P waves. I wouldn't sweat over not seeing a P wave when I see them. But my personal view about this, when I implant loop recorders, I'm normally very fussy about trying to map in various to try and get the best P waves and QRSs. So I can minimize problems. And the other thing I do is that I tend to suture. You probably learned that from the US as well. I suture the loop recorder to the floor of the pocket if I'm implanting the old-fashioned loop recorder, to try and minimize artifact, and you get better signals with that as well. There's the question: what would you do if the patient was less than 20 and you tried everything? It's a difficult one. I mean, at that sort of age, I've tried to avoid pacing as much as I can. Having said that, I have seen cases where we have had to implant pacemakers because, the patient is willing to try anything there. Most of the times, I mean, they're not as dramatic as this, but I've seen cases where they were more dramatic than this in very young people, and we end up implanting a pacemaker. My view, when I implant a pacemaker into these people, I would always sort of tell them that it may not completely get rid of your symptoms, but it will make them, less severe. But I normally discourage people, below the age of 40 from having a pacemaker, and that's my view about this. Ultimately, most of these, the guidelines recommendations is that, lifestyle measures is the first thing, avoiding triggers, hydrating yourself, lying flat, if you feel that you're going to get one of those episodes. But, it's not a class 3 indication to implant in these people. I think it's a class 2B, if I remember correctly, below the age of 40. Sometimes you just have to do it. But I think ultimately it'll end up being a discussion with the patient and just saying, it is the kind of thing that, I don't normally like to do. It may not completely cure your symptoms, but it will probably, and most of the people, even if it is a mixed response, you know, cardio inhibitory and a vasomotor sort of response, they will get some benefit out of this. And that's what I would normally do. So I haven't had yet to implant in somebody who's below the age of 20 for neurocardiogenic syncope, I have to say. Okay, so should we go to the next case then? Right, so the next case, there's no history there, but I'll show you 2 ECGs there. So this is the first one. Okay, and this is the second one. Okay, and I'll show you the questions. So what is the diagnosis? Is this Mobitz 1, Mobitz 2, complete heart block, or you can't tell? And I'll show you the ECGs again. So this is the first one, and this is the second one. So do you think this is Mobitz 1, Mobitz 2, complete heart block, or can't tell? Okay. Do you want to go back to the ECG? Or you can show us the poll. For the ECG, you can just show them the ECG. So this is one of the ECGs, and this is the second one. So it's one ECG 1, ECG 2. Okay. Yeah, I agree with the majority, which has said that you can't really tell. So this is clearly not Mobitz 1. Let's go back to the ECGs. So what you can tell here is that you've got 2 ECGs with 2-to-1 AV block. Okay, so this is clearly not Mobitz 1. And it's clearly not complete heart block because you've got a fixed relationship between the P wave and the QRS. Okay? But most of the people would fall into the mistake of calling this Mobitz 2. And I don't think you can tell just when you see a trace with just 2-to-1 where you can say that this is Mobitz 1 or Mobitz 2. We shown earlier on an example where you have a very long Winke-Back cycle, which is like 7-8 sort of complexes until you drop a P wave. But this is the other extreme of it, where your first beat in the cycle of Winke-Back along the PR interval is the same one that drops a P wave. So the Winke-Back cycle could be very variable there. This is 2-to-1 AV block. But you can't say Mobitz 1 or Mobitz 2 based on this. Because your biggest clue there, normally from a surface ECG, if you're not going to do any intracardiac study, is to basically look at how it starts. So here for this one, you can see that this starts with a prolonging PR interval, and then you go into that 2-to-1 pattern, which is more suggestive of a Mobitz 1. Whereas this one was conducting 1-to-1, and then suddenly you start conducting 2-to-1, with no change in the sort of PP interval, no change in the PR interval. So this is more suggestive of a Mobitz 2 pattern. No, the ECGs are not from the same person. So the 2 ECGs are 2 different. So it's just really just to show the different sort of physiology in these cases. And, it's just to highlight the point that if you just see a trace which is showing 2-to-1, it's important to not commit yourself to saying this is Mobitz 2, because you have to look on how it starts on the beginning of the ECG. So this is clearly with prolonging PR interval before you move to the 2-to-1 part. So this one, although it's this part is 2-to-1, you can't call this Mobitz 2. This is almost certainly due to Mobitz 1 physiology. Now you can't be 100% certain, I think, unless you do an invasive sort of EP study on this. But from a physiological point of view, for us, we always sort of question whether this is sort of Mobitz 1 or Mobitz 2 physiology. And the key is that in this trace here, the PP interval doesn't change. Okay, but suddenly you move from conducting 1-to-1 to conducting 2-to-1 with pretty much the same PR interval, no change in the PR interval. So this is sort of almost certainly due to a Mobitz 2 physiology, whereas the first ECG is more likely to be to a Mobitz 1. Now this is, you wonder, well, this one has got evidence of infranode sort of, disease. Yeah, but I've got a comment here. The PR interval during 2-to-1 AV block is short, whereas here it's longer. But that's the whole idea. So your first beat. So normally in a typical Winkeback, the PR interval after the drop beat would be your shortest PR interval. So if you look at the ECG, so and that's what we would normally advise people, is that always whenever you get in a typical Winkeback sort of pattern, you look at the P wave, always look at the PR interval after and the PR interval before before the blocked one. Now you can't do that in this case, but normally the PR interval after the drop P wave is going to be the shortest, because that's going to have had a long time for it to recover. Whereas here you've got typical sort of Winkeback, so it's prolonging. So if you look at this one is shorter than that one. So this is clearly Winkeback here, and this is now 2-to-1. Okay, so just the fact that it's the key about this case or these two ECGs is that although sometimes you see 2-to-1, it's important to know that 2-to-1 does not really infer Mobitz 2, which is what most of when I show this trace to fellows, they would always look at it and say, well, this is Mobitz 2 AV block. And no, it may still be Mobitz 1. And the key to you is really to look at how it starts, how it transitions from the area where you've got 1-to-1 conduction. Okay? So, this, and this is a bit unusual because this patient's clearly got, signs of His-Purkinje disease. I mean, the axis was deviated, and you've got a bit, I think, of a right bundle branch block. So this patient has clearly got signs of infranodal sort of disease. But I think in this one, still, the physiology of the 2-to-1 block here is probably Mobitz 1. You can't be 100%, but this is most likely to be Mobitz 1, I would say. Okay, so we said the Winkeback cycle can be very long and involves multiple QRSs, but also can be short and involve only a single QRS. So the first one that's supposed to prolong the PR interval is the same one that blocks, and therefore you can never see a prolonging PR interval, which you would normally see in a normal Winkeback. And the key in the diagnosis is see how you transition from normal sinus rhythm with 1-to-1 conduction to the 2-to-1 AV block. Okay. Let's show another one. So this is a patient who's got a biventricular, I think it was a biventricular pacemaker, who was admitted with decompensated heart failure. And in fact, he had about 3 admissions in about 3 months or 2 months. And yeah, I've got a comment here. It's better to quote 2-to-1 AV block. Absolutely. You can make more comments if you can see how it transitions from conduction to the 2-to-1. But if you've got a trace with only 2-to-1, you're much safer just saying this is this is AV block with 2-to-1 AV conduction than saying, well, this is Mobitz 1 or Mobitz 2 AV block. Okay, so patient with biventricular system admitted with multiple admissions with heart failure. This is his ECG. So I'll show you the answers and then we'll go back to the ECG. So do you think the patient is having sort of loads of heart failure admissions because now he's got atrial fibrillation, or you think that he's got just progression of his heart failure? You think there's only RV pacing or LV pacing, or you don't know why he's maybe drug compliance or something? Okay, we'll go back to the ECG again. And then when you're happy, Khalid, you can give them the poll. So give them another 20-30 seconds to go through this. So this was when I was working in a hospital that didn't really have a lot of EP or devices input. And yeah, absolutely correct. Good. We can go back to the ECG then. And the patient was very disappointed because he felt that getting his BiV pacemaker was going to make the biggest difference in terms of his symptoms. So as you all sort of correctly identified, what we're having here is really just RV apical pacing. Okay, so you can tell this because this is a left bundle branch block more negative lead concordance, so it's very close to the apex of the heart, and it's coming from somewhere inferior. So it's it's RV apical pacing from what you can see, which is not really what you would want to do when you've got somebody who has heart failure. You don't really want to pace their RV 100% of the time. The idea is that you want to try and synchronize both chambers. So I obviously got a programmer and sort of checked the device, and this is the morphology with LV only pacing. Okay, so you can see with LV only pacing that you should really have a right bundle branch block morphology in V1. So because if you're pacing from the left ventricle, it will be heading towards V1, and therefore you're going to have a positive QRS complex in V1. So because it's coming from the left towards the right, and V1 normally sits on the right side of the chest. And also, if you look at lead 1, it's a predominantly negative QRS because, again, you're moving away from lead 1, which looks at the heart from the left side. Okay? And this is when, so I'll show you the first one, which was the RV, whereas here you can see that this is predominantly positive in lead 1, and it's negative in V1 because it's moving away, so it's moving from the right towards the left, and that's why it will look negative in V1. And this is LV pacing, as we said, and this is when we got BiV pacing. So now you've got a narrower QRS complex, you've got a bit of an R wave in V1, and you've got a negative component to lead 1. So this is what you would expect when you do BiV pacing. You're trying basically to have a fusion between between the left bundle branch block morphology that we would normally implant the pacing system for, and the pacing from the left ventricle to try and give you a narrower QRS complex. Now this patient had his device implanted and his initial check was fine, but the LV threshold went up a little bit, and it went up just a little bit above the output, which was programmed from the battery. So although the device was delivering a pacing spike from the LV lead, the threshold was lower than what he's supposed to be able to capture the LV, and therefore this patient was getting 100% RV apical pacing, and that was practically making his heart failure worse. And since he had that sort of reprogrammed to that, I followed him up for 6 months while I was still in that hospital, and he hasn't had any further admission. He was feeling better, so his symptoms improved after that. So my key point about this is always try to understand RV morphology for pacing, LV morphology for pacing, and try to understand when you get BiV pacing that you actually truly have BiV pacing. Okay, so make sure that you have BiV pacing, have a CRT system. With LV pacing, you should have a positive QRS in V1, and you should have a negative or predominantly negative QRS in lead 1. So that will change a little bit depending on where your LV lead is implanted. In general, you can see the point. If you've got an LV lead which is contributing to things, then things should be moving away from that LV lead, and therefore you should get a negative QRS in lead 1 and positive QRS in V1. Okay? Any questions there? How much time do we still have, Khalid?
We'll do one more case and that's it.
Okay. Let's find, should we find a... Okay, this is a bit of a fun case then. So this is an X-ray. So this is not an ECG. So this is an X-ray of somebody who's clearly not well. He's got a chest tube, but he's got loads of things attached to it. So what do you think is going on there? Okay, and I'll give you the answers, and then. So do you think multiple cell phones, transcutaneous pacemaker, subcutaneous ICD? Is he hooked up to electric chair and they're going to execute him? Do you think it's a suicide bomber vest? Okay, I'll take you back to the X-ray. There's no poll for this one. So this is something called a wearable defibrillator or a life vest. And the guys in the US will probably have seen it, and they know what it is. It's not that common here in the UK, and I suspect it's really not common in the Middle East as well. But it is normally, you know, an ICD that the patient can wear as a vest, and here's a sort of an image of it. It'll have pads on it, and it'll have like the circuitry that will detect the VF. And here's the chest X-ray, which is, you know, the PA and lateral. So normally you put these devices on if you've extracted an ICD and you don't feel the patient is safe enough to go home without a, you know, a device backup. So you give it to them until, you know, infection settles down. Or if you have somebody who presents with a newly diagnosed heart failure and they, you know, they need to be treated medically to optimal medical treatment before you consider implanting a device. And if you worry too much about them, like they've got non-sustained VT or something, you're worried that they might go home and drop dead, then a wearable defibrillator or something called the life vest is going to be, you know, a useful option there. The newer version of it is really not going to have that vest, and it's going to really be, it's going to be adhesive. So you're just going to stick it to the chest wall, and you'll have another patch which sits there. So it's not going to be like a vest. It'll be just, you know, stuck to the chest wall, wearing this thing on until a final decision is being made. Okay. Do you want to see another one, or is that it?
I think Mu'taz will open the floor for questions.
Okay.
I was wondering if we have any questions from the audience. Well, Mu'taz, it's an outstanding presentation. Really enjoyed it, and thank you very much for presenting today. I think there is someone is typing a question. Okay. If we don't have, I don't know, do we have any questions? Fathi, do you want to, do you have any questions for Yusuf? Or maybe Nadia, if still with us? Okay.
Nadia was clearly grilling me on the EP questions there.
I really enjoyed it. Both presentations were exceptional. Was a nice overview by Ayman for interventional cardiologists. And obviously, I'm very biased whenever I see these ECGs, traces. I get so excited. And Mu'taz, seriously, you did an outstanding job. I thoroughly enjoyed it. Thank you very much, everyone, for attending. Hopefully, our next webinar will be sometime in April. We will send email soon. I can't remember the date. Yusuf, do you remember the date? But I'm sure either myself or Yusuf will send you an email to confirm the date. The date is the 17th of April, which will be a Sunday. So hopefully you could pencil that in your calendar. And we're looking forward to see you all. And once again, thank you, and thank you to everyone who attended today.
Thank you very much. Bye-bye.